good morning, everyone. I think we'll probably get more people to join as we move forward. But it's my great pleasure to introduce Teddy Mamo. He's going to speak on the crucial role of laboratory medicine in powering the growth of cellular therapies. Teddy came to us, I'm probably going to get the years wrong, Teddy, but like kind of early into the pandemic. Well, maybe I should first, I'm going to start with his training. So he received his bachelor's degree from the University of Waterloo in Ontario, Canada. And this was in nanotechnology engineering, which I think, at least I wasn't thinking about nanotechnology at that time. So I think Teddy is has always kind of been on the forefront of activities, and he's going to kind of continue, I think, with his career on that forefront. After he received his bachelor's degree, he went to, you may have heard of it, it's an institution south of here, Mayo, and got his MD, PhD there. He did research on pediatric tumors, I think osteosarcoma, if I can remember correctly. And kind of based on that, he decided to go into pediatrics and started at UT Southwestern. And after several months, kind of into that first year, he kind of realized that he enjoyed kind of the laboratory aspect more than kind of the clinical end. So he reached out to us, I think he connected to us through Amy Carger, and reached out to me with his interest in cell therapy. And we were fortunate enough to bring him here as a postdoc, my first and only postdoc ever. And he focused on several things and projects in cell therapy, published those in great journals, and then kind of joined us from there in CP. He was a CP-only resident and did his year in transfusion medicine last year, as his first slide says. And he was a great fellow. We were lucky to have him there, lucky to have him overall. We were very lucky to have him. And I'm looking forward to this talk. I did tell Teddy that I am going to have to leave a little early to do a consult, so I apologize. If you see my name drop off, then I'm not being rude. I'm kind of very sad. I'm going to miss part of this. But anyway, without further ado, Teddy Mamo.
Thank you for the introduction, Dr. McKenna. I also have enjoyed my time here, and I'm looking forward to share some of the work we did. So the title of my talk, as Dr. McKenna mentioned, is to talk about the crucial role of lab medicine in continuing to power the growth of cellular therapies. And I'll touch on some of the projects that I got involved in as I talk about that going forward. So my objectives today will be to discuss the role of lab medicine in collecting the starting material for cell therapies, and then how we manufacture and do the quality control. And then finally, focus on this new and upcoming important aspect in cell therapy, which is biomarker testing to monitor the treatment. And I have no disclosures. So to get us started, as an introduction, I see cell therapies as a continuation of this blood-derived therapeutic products. We all know the use of blood in various treatments to this day. So the whole idea of cell therapy started with that, and that's why blood is known as the first cell therapy. And just to give you some history for that, the transfusion of blood began in humans in the 1800s. Before that, in the 1600s, it was tried in animals. Actually, dogs were the first to receive transfusion. And then later on, we were able to separate the blood into different parts, and now we have RBCs, platelets, plasma, and all those things. So this was the first kind of cellular therapies that we give from other patients to patients, from donors to patients. And then that continued forward into this era of plasma-derived therapeutics. And this started in the 1940s when this technology of ethanol fractionation by Dr. Cohn, not our own Dr. Cohn, and they're not related, but just a coincidence. It's now known as Cohn fractionation. In the 1940s, that began the era of plasma-derived products, and these are now standard therapeutics that we're all familiar with, such as IVIG, albumin, clotting factors. All of these were possible because we were able to have this technology to derive these medicines from plasma. And that got even better when the technology of plasmapheresis was established in the 1960s. This machine, which we now call apheresis, initially was just used to derive plasma for these plasma-derived products. And then we continue into the era of the cellular therapies, which really kicked off in 2017 when FDA approved CAR-Ts. But before that, in the 1950s, the early beginning was in bone marrow transplant, where we can now obtain cells, bone marrow cells from patients, and transfuse them for various applications, especially in hem-onc. And then this got even better in the 1970s when apheresis was used not just to obtain plasma, but also the various type of cells, such as white cells or RBCs separately from blood, and then now we can use them for different applications. And this was very crucial when CAR-Ts were developed as well, when we are now able to obtain white cells from the blood and then modify them and make them into these very exciting cellular therapies. So after that, since by December 2024, we have over 40 cell and gene therapy products that are FDA approved. And some of them are now really well established, such as, like I said, hematopoietic stem cell therapies, HPCs, or CAR-Ts. Since 2017, now they're very well established and now are entering standard of care. And then recently, there has been more approvals and more therapies, such as tumor-infiltrating lymphocytes that got approved in 2024. And very, very recently, MSCs were also approved in December 2024. And there are still a few type of cells that are still in development and that are not approved yet, such as NK cells and Tregs. So the ones that have bolded, the CAR-Ts, MSCs, and Tregs, are the ones I will highlight throughout my talk today. And then this figure here shows you the different type of therapies and the companies involved, especially the indications. And as you can see in this figure, the majority of indications so far are for hematologic and oncologic diseases, but this is expected to grow, especially these days in the application for autoimmune diseases. With that, just to give you an overview before I get started with the different parts of my talk, is this cell therapy life cycle is very unique compared to other therapeutic products. These therapies don't just come to the pharmacy and then get given to the patients. So I'm going to focus on three different aspects of the cell therapy cycle, which is the beginning, which is the starting material, where we obtain the cells from patients. Usually this happens in the clinic. And then the cells have to be manufactured, sometimes at the local institution, or they get sent to the company. And then the cells are back and then gets infused to the patient, either in clinic or in the hospital. And with that in mind, I've divided my talk into three parts. In part one, we'll focus on the starting material. And then in part two, I'll focus on the discussion on manufacturing and quality control. And then part three, like I said, after the delivery of the therapy, now biomarkers to monitor the treatment response are becoming very important. And I'll highlight some of that in part three. So hopefully we'll get through all of them, and I'll try to be brief and don't go into too much detail. So in part one, we'll talk a little bit about starting material. Starting material is very crucial for all types of CGT products to have to manufacture successful and effective therapies. The starting material has to be good. And for autologous products, which is products that are obtained from the patients and given back to the same patients, usually the cells have to be obtained from the patients in the clinic. And like I mentioned earlier in my intro, apheresis is really what has revolutionized this, and now it's the standard way of collecting cells. And we can collect the different parts of the cells that we want from the blood. And what I want to highlight here, and I'll do this throughout my talk, is really the role of the different parts of lab medicine. Here in lab medicine, transfusion medicine, and as well as cell therapy labs, which are called in some institutions cell processing labs, are very crucial in this stage of the process, where apheresis departments are, for the most part, across institutions, are led by transfusion medicine. Some of them are led by hemonc or nephrology, but transfusion medicine plays a big role. And as cell therapy is taking hold, more departments are trying to include transfusion medicine in their apheresis units. And this is very crucial in obtaining the cells. And then the cell therapy or the cell processing labs are very crucial in then processing those cells, whether they're manufactured at the institution or they get sent to the company. So this is the first department within lab medicine that's crucial at this stage that I wanted to highlight. So as an example of starting material, I'm going to present one of the projects that I was involved in. This was presented at the AABB in 2023 in Nashville, and then the paper is now resubmitted to the Journal of Transfusion Medicine. And here I'm going to focus on CAR-Ts and the role of starting material in CAR-Ts. And as I've mentioned, CAR-Ts we all know are the poster child of cell therapy, and now they're very well established. But CAR-T stands, just to be complete, stands for chimeric antigen receptor T cells. And as we all know, it's designed by putting these receptors within T cells that can target tumor cells. And we now have about 6 FDA-approved products. But what has been happening now is as more CAR-Ts get approved and more companies are involved, all of the companies have their own apheresis collection parameters, which I will call ACPs going forward. And these parameters are not the same, and every company has their own requirements, not only just for the apheresis collection, but for the various steps and processes. And this has created some overload in the apheresis units, especially with more clinical trials being developed. The different requirements are creating some challenge within the apheresis units. So with that in mind, I started to wonder during my rotation on apheresis for cell therapy, why do these companies have varying apheresis parameters or ACPs, and where did this come from? So we tried to analyze this and see if there is a way to standardize this. So what we did is we assessed if these parameters were based on the pivotal clinical trial study protocols or publications, and then whether transfusion medicine or apheresis expertise were involved in developing this. And for that, we looked through the SOPs from each company. We also reviewed the pivotal study protocols, like I mentioned, which are mostly published in New England or the Lancet. And then we reviewed the publications, like I said, to review the author affiliations, either in PubMed, and then we tried to verify their affiliations either on the website or on LinkedIn if available. And here is the summary of this. For the sake of time, I'm just going to focus on the final 2 figures. And as you can see in this table, we have the 6 approved CAR-Ts on this side. And these are the name of the trials. As you know, trials have really fancy names, just like hurricanes. And these are the 6 approved trials here. And then here I've listed the apheresis parameters that were listed in these studies. As you can see, only 3 out of the 6 CAR-T companies mentioned apheresis parameters within their clinical trial protocols. And then when looked through the publications, only 1 of them actually mentioned an apheresis parameter in their final publications. In terms of the authorship, we didn't find any transfusion medicine trained physician as author in these major publications. There was one who was associated with the transfusion department, but was not even transfusion trained. It was a hemonc trained person that was involved in developing CAR-Ts. Then we tried to understand this even further by comparing it with the SOPs. Like I said, all CAR-T products have SOPs that specify specific required apheresis collection parameters. And when we looked at those and compared them with those in the protocols, we did see that they are similar. Those who mentioned the parameters in their protocols, they do have the similar kind of requirements in their SOPs. And when we tried to see if we can find some common ground, the one consistent thing that we found that I listed here is that target cell count appears to be the main parameter that has been consistent, at least for those who listed their parameters in their protocols. And the 2 major ones are it's either target cell count or the apheresis blood processing volume, APPV, that I mentioned here. So it's either the volume or the target cell count that is mentioned. So with this in mind, our recommendation in terms of starting to standardize these collection parameters was, focusing on target cell count could be ideal. And for this, we chose the CD3 count as the target cell count, both pre and post collection. And this is based on, at least we have one CAR T that does this from the approved ones. And also from our experience in stem cell collection, we do use CD34 as the only required apheresis parameter for standard stem cell collection using apheresis. So we do have experience with the CD count there. And in cases where maybe flow cytometry is not available, then we suggested ALC or absolute lymphocyte count could be an alternative. And then for processing volume, we suggested that maybe a guidance of 10 to 15 liters of apheresis blood processing volume could be provided as a guidance, but not a requirement, so that every apheresis unit can kind of adjust based on the target cell count. And in the literature, some people in the literature also support this, and so we provided this as a recommendation in our paper and also in the abstract. But this requires a lot of work, and standardizing things are not easy, as most of you are aware. So in the future, this really requires, and this have begun already, but a collaboration with the various societies, and also standardizing groups such as FACT and from the US and JC from Europe, as well as the various societies involved in cell therapy, to have a discussion with manufacturers, but as well as, really, like I said, I want to emphasize the role of transfusion medicine or apheresis physicians to be involved in these discussions, as well as in future clinical trials, to make sure that these apheresis expertise are utilized before things are standardized and FDA approved. So that's the first part of my talk, and now I'll transition into the second part, which is the manufacturing and quality control of cell therapies. So once we get the starting material and once we have the cell to start with, then the key aspect of cell therapies is manufacturing them, and this is what really propelled the growth of cell therapies. And obtaining clinical grade cell and gene therapies requires GMP facilities and clinical grade reagents, and then very, very specialized techniques to make sure that these cells are manufactured properly. Selecting once we get cells from the apheresis, they're kind of a collection, even if when we say white cells, they have all kinds of white cells within them. So we have to be able to select the specific cell type that we want. Then they have to be activated, and then in some cases, modified genetically with either gene delivery or gene editing. So a lot of techniques are utilized in manufacturing. And then finally, very important aspect is also product specification and release criteria, which is really what helps with the quality control to make sure that the cells that are manufactured meet the specific criteria and are the cells that we desire. And then before these cells are reach the patient, an important aspect is then storage and transportation. And under this, cryopreservation is a very critical step. So before I go into the details of this, I want to highlight again the role of lab medicine. And here, a lot of our departments in lab medicine are critical here. Like I mentioned earlier, cell therapy labs or cell processing labs are very critical, especially if the cells are manufactured within the institution. For example, here we have a GMP facility where we are able to make products for clinical trials. So that's a very important aspect. But additionally, various departments such as HemePath and micro and molecular labs are also very important, especially in terms of the release criteria and making sure in terms of doing the quality control, where we use flow cytometry and also testing for organisms, and also for the gene therapy. A lot of the genetic testing that we do are also important in the final process before the cells are ready. So a lot of these departments I wanted to highlight in terms of how they're critical in manufacturing cell therapies. So to give you an example of the manufacturing process, I'm going to highlight two projects that I was involved in. The first is a review on Treg manufacturing, regulatory T-cell manufacturing, and I'll highlight some unique aspects. And then the second one is on cryopreservation of MSC cells. This was an abstract that was presented at the ICT annual meeting 2023 in Paris, France. And also the paper has come out in cytotherapy recently. This is a multi-center study, which I will highlight some of the results. With that, I'll focus on the Tregs first. So regulatory T cells are specialized T cells that monitor the immune system, and they suppress overactive T cells. We heard this a little bit yesterday at the CP conference when Ahmed presented about an autoimmune disease. And for this, they're known to be, if they're inhibited, they're known to be involved in autoimmune disease. They're T cells with this signature marker. They're CD4 positive, CD25 positive, and they have low CD127 expression. But an important part is also this FOX3 intracellular transcription factor, which is a signature of regulatory T cells. And like I said, because of their role in autoimmune disease, these cells have been explored as an application where we can adaptively remove and process and prepare these Tregs for application in autoimmune diseases. The first to be tried on were type 1 diabetes and also organ transplants. Like I said in this figure here, they're involved in affecting the various immune cells, especially through the antigen presenting cells. So here in this review, we highlight different state of manufacturing Tregs for application cell therapy. In manufacturing, like I said, it starts with the starting material. For Tregs, the majority of the source has been either peripheral blood mononuclear cells that are obtained through apheresis, or in some cases, umbilical cord blood could be also used as a starting material. Then an important step then is, like I said, is selection. In selecting cells for cell therapy, the two standard methods are immunomagnetic selection, or FACS could also be used to sort out and select the cells, although immunomagnetic seems to be the most commonly used. Then we obtain the specific Tregs, then we have to activate them. And there are few methods to do that, incubating them with beads or antigen presenting cells that will lead them to be activated. Then a critical step is to expand them so that we have enough cells for clinical application. And then finally, they have to be purified by removing the beads. And then flow cytometry is usually used to make sure they're pure. And then the final product can get infused into the patients. And here I wanted to highlight specifically for Tregs, two important steps are the activation and then the expansion to make sure that we have enough Tregs available for the cell therapy. In table 1 here, what we wanted to highlight is, we reviewed a lot of the different, at the time, the different existing procedures that were used, and we listed a lot of the different projects and different publications at the time. Here we have a summary of the protocols used for the different procedures. They're slightly different. They are listed here. But what I really wanted to highlight with this table, again, to emphasize the role of the different departments, is the release criteria. And here, we have to have a viable cells, and we specify a certain percent. And for example, in this work, which was actually done here at the U, in collaboration with our MCT lab and as well as our Hemon colleagues. And as you can see here, viability is one important aspect, but also the fact that, do we have the required T cells or Treg cells with the CD4 positive, CD25 positive? The specification here is over 60%. As well, again, here, the role of micro, these products have to have no grows in this product. At least, the requirement is to have no grows, and then endotoxin level as well. And then here in the second example here, you can see even further requirements such as negative aerobic and anaerobic and fungal sterility culture, negative mycoplasma, negative gram stain. Currently, I'm on micro, and these are the things that I'm learning, and they're very crucial in the cell therapy process as well as the purity and, with flow cytometry. And again, here in this line, you can see how flow cytometry is critical in making sure that we have pure products. For this paper example, we can see that over 95% are what we think are Tregs. And then the FOX3 expression is over about 60%. And here in this, we even have a better, pure product, over 99%, and then over 80% FOX3 positive. I want to conclude this part by saying that, like I said, there has been some progress in some clinical trials, and I won't go into in the paper, the clinical trial results that we mentioned. But in terms of the manufacturing, the ones that I gave as an example, using these beads that are used to activate, we make what are known as polyclonal Treg cells. And then when we use antigen-presenting cells, we make antigen-specific Treg cells. So these are the early forms of the Tregs that have been tried in clinical trials. But more recently, now there has been efforts to engineer Treg cells further into CAR Tregs and also T-cell receptor Tregs to make them even more specific and targeted, as the early trials are not really it's been now over 2 decades when these Tregs have been tried, and we have not made a significant progress. So these are being tried as alternatives to make these Tregs even better. And now the first in human CAR Treg have taken place, and the phase 1 and phase 2 studies are ongoing. There's a company pursuing this. And here at the U as well, and Dr. McKenna and our heme colleagues are involved. There are some projects ongoing with CAR Tregs as well. And that's the future. So hopefully sometime soon we'll have the Tregs get approved as well. Before I proceed to the next part of the manufacturing example, I just want to take a pause to give you a mental brain break. And this is a picture of one of my favorite places when we are in Paris for a conference. This is the Versailles Gardens and Palace, and this was really amazing. And if anyone has not been to Paris yet or has not been to this garden, I really highly recommend it. It was very beautiful. Okay, with that, I'll transition to the other example I want to give was manufacturing, which is MSCs, mesenchymal stem or stromal cells. Are the other type of cell therapies that are being explored. These are cells that are derived from the bone marrow or adipose tissue, or in some cases, umbilical cord. They have key specific properties that, in this figure that you can see, the ICT defines that MSCs should meet these 3 criteria, which is they have to adhere to plastic, and they should have these markers, and then they have to differentiate into different cells. But another important aspect and why they have been people have been excited about them is also their involvement in immune modulation. And for markers, these 4 could be even enough to say they're MSCs. And the MSCs have recently, after many, many years of hard work, have been recently approved in December 2024 for an application of steroid-resistant acute graft versus host disease, or GVHD, for pediatric patients over 2 months. So this is a very exciting time for the MSC field. But one important aspect as they were being explored that has been challenging for MSCs is their storage and preservation, and this was believed to may have an effect in their efficacy. That's why I'm going to focus for a little bit on this paper that we published, which is on cryopreservation of MSCs. This was a multi-center international collaboration, a BEST project with collaborators from Europe and Australia, as well as here in the US from NIH and a few institutions. So cryopreservation is an important process in cell therapy because sometimes the cells that are manufactured don't get given to the patient right away, so they have to be stored. And when we cryopreserve cells, a very important step is we have to make sure that when we freeze the cells, these ice crystals that form within the cells don't kill them. So for that reason, we use cryoprotectants, and the standard cryoprotectant used currently is DMSO. However, there are some disadvantages of DMSO, and especially for MSC, people have been exploring other ways to cryopreserve and to identify unique and novel cryoprotectant solutions. So in this study, we tested this novel cryo solution, which I'll call SGI going forward. It's made from sugar molecules as well as an amino acid, isoleucine. I won't go into the details of the specific formulation for this because after this project was started, this molecule or this solution is now licensed to a company called Eva Bio. This solution was initially started by Dr. Alison Hebel in mechanical engineering here at the U, and now is licensed and is being developed by the company. So I won't go into the details since now it's proprietary, but I'll present some of the study that were done before even the company got started, which is to compare this SDI solution with the DMSO in this international study that I mentioned. So this is a summary of the study design. 7 centers were involved. 6 of them had bone marrow derived MSCs. 1 had adipose derived MSC. Then the cells were cryopreserved either in the SGI or DMSO solution, and then cryopreserved. And then we did some testing to see if the SGI solution still keeps its property. And I'll highlight some of the results, not all of them for the sake of time. The first thing we did is to see if after cryopreserving them, do the cells actually recover pretty well. And as you can see here, we are comparing first in the left side here for the different centers, the SGI and the in-house DMSO-based cryoprotectant. And as you can see in terms of the recovery, which is defined as the cells after freezing versus post-freezing, their viability, the ratio of their viability is compared. And as you can see, most of the centers had a viability close to the average for both the SGI and the in-house solution. And then when we combine all of them here, you can see we had a recovery of about 93% for the SGI, and it was slightly lower in the in-house. As you can see, we did have an outlier center that dropped the value a little bit, especially for the in-house, which we believe this is just technical related to that specific lab. But overall, this was a good result in terms of showing that the SGI was able to cryopreserve this MSC cells. And then here we check the surface expression of this MSCs. Like I said, there are some signature markers for showing that MSCs are the cells are actually specifically MSCs. And here we compare the fresh MSCs with the SGI and the in-house, and they do behave similarly with both the fresh and the in-house MSCs. Those cells that were cryopreserved in the SGI, where they have low CD45 and they have really good expression of the other markers. I won't go into the gene expression result for the sake of time, but that also showed that those cells that were cryopreserved in the SGI had similar gene expression as those cryopreserved in the in-house. So to conclude this part, we've shown that MSCs could successfully be cryopreserved in a DMSO-free cryoprotectant solution. The ingredients of this SGI solution are regarded safe by FDA, and they're already being used in various existing products. So this is kind of supports potential for clinical studies using this solution. But before we get to that, actually, there's one more study that needs to be done, which is the functional studies, to make sure that the MSCs, although they do look like MSCs, we have to make sure that they behave like MSCs with cell proliferation as well as immunomodulation, because there are concerns after you cryopreserve cells, there may be heat shock, or they may lose their interferon gamma licensing properties and the other immunomodulation properties. So we have to make sure that's the case. So that concludes the part on manufacturing. Like I said, manufacturing using the T-Rex and the MSCs and cryopreservation, all these steps are important. So before I go to my final section, again, one more picture here to give you a break. This is the other side of the Versailles Garden in Paris. Really beautiful, really amazing. This picture, I didn't take it myself, but it's really, really, really nice. So I highly recommend it. So the final part I wanted to focus on is the role of biomarkers in monitoring cell therapy response. And to see why and when do cell therapies work, like I said, there's been a lot of excitement with cell therapies, especially with CAR-Ts working really wondrously. But we do know that they don't work all the time, and it's time now to kind of learn why do they work and when do they work. And this is variable for different cell types and for different indications. So here I wanted to highlight again the role of lab medicine, and chemistry, hemat, and molecular labs really become important when it comes to this. And I'll highlight this with one of the projects that I was involved in, and how the various markers that get tested are really driven by these departments. And I just wanted to highlight again the role of these departments in lab medicine going forward in cell therapy. For this, I want to, as an example, I'm going to focus on this paper we published in 2024, which is emerging biomarkers for monitoring CAR T cells. This was done in collaboration with our collaborators at NIH. Dr. Stronsing, and as well as a hem-onc fellow at the time, who's now a faculty at NIH as well, who I worked with very closely, and we are both first co-authors on this paper. So in this first figure, what we did was we divided CAR-T biomarkers into two major groups, which is pre-infusion biomarkers and post-infusion biomarkers. And even within those, we divided them into patient-related and product-related biomarkers. So for the patient-related biomarkers, before they are infused into the patient, we can get some information in terms of the state of the patient, in terms of the disease burden and things like that, and the various lab values of the patient. And then before the products are infused, we can measure this at different stages of the manufacturing, or right when the cells are obtained from the patient, from the leukapheresis product, or right before it gets infused into the patient. So getting an idea of what kind of characteristics that this product have before it is infused, and seeing if there's any correlation with the treatment response could be a very important aspect. And then finally, in the post-infusion biomarkers, again, we can look at the patient-related and product-related again, because we can see, in addition to the response by the patients to the therapy, we can also look at how are the cells behaving once they're in the patient. So to highlight that, I'm going to present the two major tables in this paper. In table one, we focus on the pre-infusion biomarkers. And again, we divided it into patient and product-related. And we identified through the literature a lot of the factors or markers that are believed to show response, whether good or bad response. Here we highlight the different processes, and then we classify them into those markers that give good response and those that give poor response. And what I wanted to highlight here is the ones that we consistently have seen repeatedly in various publications that have been shown to be good markers. And what you can see here is that patients who have pretty high disease severity before the CAR-T infusion, such as either whether they're late stage or they have larger volume size of the tumor or things like that, or they have circulating tumor DNA. This was seen in lymphoma projects or lymphoma trials, where if there is circulating tumor DNA already available, then that's a marker for poor response of the CAR-Ts. Other examples, for example, for the good responses, response to lymphodepletion is also seen to be a good marker. If they respond really well to their lymphodepletion, then which can be measured by the level of IL-7, MCP1, IL-15, then that could also lead to a good response to the CAR-T. When it comes to the products, I wanted to highlight very important aspects here, which is the type of T cells that are actually, once they're obtained from the patient, the apheresis, and then even our selection doesn't divide the T cells into different parts. It's all T cells. But when the studies have seen the type of T cells that are in the majority in the CAR T cell product, it's shown that when naive or early memory T cells are involved in the CAR T product, then patients show good response, versus when effector memory T cells or cells that are exhausted, which means they're in the late differentiating stage, which can be measured by markers such as this TIM3, PD1, LAX3, or CD69, those are shown to have poor response. Another interesting aspect, again, I talked about Tregs in the manufacturing when they're used for autoimmune disease, but when it comes to CAR-Ts and their applications, especially for hem-onc applications, the presence of Tregs in the CAR-T product is actually a marker for poor response. And then in the second part, looking at the post-infusion biomarkers, again, we divided them into patient and product related. Again, there were a few things that we identified, but the key biomarker that has been consistently found to be important is the MRD status of the disease after the patients have received the CAR-T. This has been shown consistently. If after the patient received the CAR-T, if the MRD is checked, 3 to 4 weeks after the treatment, if they have good MRD, then they're shown to have good response to the CAR-T overall. Another important aspect is also the product-related biomarker. And even after the CAR Ts are transfused, we can measure CAR T levels in the patient. And patients who have good T cell expansion and persistence, which can be measured with the CAR T levels in blood, if they are persisting between 2 to 4 weeks after infusion, that's an indicator for good response. If they have already disappeared from the blood or they're really low levels within 2 to 4 weeks after infusion, this has been shown to be an indicator for poor response. So that was very important as well. Again, I wanted to highlight, even after the infusion, if Treg levels are measured in blood and they are higher, that's a marker for poor response of CAR Ts. So these were all very, very interesting results. Like I said, I didn't get into the other ones. For example, B-cell aplasia for patient-related products is also important to see B-cell counts afterwards, because CAR Ts are targeting B cells. And if we remove them, then that's a good marker. CRS, we are all familiar with cytokine response. Cytokine release syndrome, which is if there's moderate grade CRS, that's an indicator for CAR Ts to work. So this is mentioned as a side effect of CAR Ts, but it's also a good sign, because then the patients tend to respond pretty well. The cytokine levels, like I said, and the ferritin and the CRP, all of these are also important. Actually, I'm going to go back a little bit here, similar to that for infusion biomarkers. The level of inflammation is a negative marker, actually. If patients before transfusion, before the infusion of the CAR Ts, they have high levels of inflammation, which is noted by increased LDH CRP, that is actually a poor marker versus, after the infusion, if they have the CRS and cytokine release, that's actually a good response, which means the CAR T is working. So with that, I would like to conclude this section of the biomarkers. Again, what we concluded in this review, what we have identified consistently through reviewing the literature, is that the ideal biomarker for cell therapies has to correlate to treatment response, and then has to be reliably measured with already available standard laboratory equipment, as well as it has to have a clear, clinically relevant cutoff values to be able to be an ideal a biomarker. And in this work, we have shown that for CAR T specifically, the consistent predictors of treatment response are the disease burden and the response within like the first 3 to 4 weeks, which is the MRD status, like I mentioned. This has been, although we've seen a lot of other markers, this seemed to be very consistently important. And then post-infusion, we, like I said, the CAR T persistence and expansion between the 2 to 4 weeks after infusion is very critical as well to show that the CAR Ts are working and have a long-term response. A very important point that I wanted to highlight here is we did mention pre-infusion product-related biomarkers, but there is a challenge with this, because most of currently approved CAR T products, they actually don't want you to touch the apheresis product before you send it to them, or once the product comes to be infused into the patients, they don't want any contamination to the product, so they don't want the centers to touch the cell therapy product or the starting material. So this has been a really big challenge, because then that means we don't really know to be able to get this product-related biomarkers other than the clinical trials, except for one CAR T company, which does allow obtaining products and actually obtaining some markers before we even send the products to them. Most of the companies don't let you touch. So this has to be solved in the future for us to be able to use this pre-infusion product-related biomarkers in clinic as we evolve with therapy. And like I mentioned with the starting material topic, this requires a collaborative approach going forward, whether it's for this aspect or for all aspects of biomarkers. Clinicians on the floor and in lab medicine really need to communicate, as well as clinicians and academic institutions need to collaborate with cell therapy companies to continue to evolve this important, especially the pre-infusion product-related biomarker. With that, I would like to summarize my talk. today, what I've tried to do is talk about three major aspects of the cell therapy. We talked about the starting material and the importance of standardizing cell therapy collections, collecting cells for cell therapy. I used the example of CAR-Ts and how different companies having apheresis collection parameters of their own is becoming a problem, and the need to standardize. And like I said, this requires collaboration among different societies and the manufacturers themselves. In the second part, I tried to emphasize manufacturing and the important aspects of manufacturing cell therapies using the examples of Tregs and MSCs. And as I've shown, this continues to evolve and improve. There are some exciting things coming up as we continue to improve the manufacturing process, as well as the role of release criteria and quality control in this process. And then finally, I've touched on the importance of biomarkers going forward for CAR-T response. We divided them into patient and product related, as well as pre and post infusion, and how currently we have a lot of groups. Eventually we have to come up with the unique and specific important biomarkers, and that's what we tried to do in our review paper to kind of highlight which ones are important, which ones stand out. And again, throughout my talk, I've tried to highlight the role of the various departments in lab medicine in all of this process and how it's crucial going forward for this process. And again, I didn't touch on our AP colleagues here, but as cell therapies move into the world of solid tumors, the role of AP is going to also increase and become very important. For example, for tumor infiltrating lymphocytes, the cells are actually obtained from the tissue, from the OR, and then the cells are developed not from blood, but actually from tissue. So this is going to become important in the future. So all of pathology, both AP and the CP and the lab medicine side, will eventually become really critical and important. In terms of future directions, like I said, starting material is very important, and this going forward, the discussions with manufacturers and societies is going to be important to make sure these are standardized and available for all of the cell therapies that are being developed. When it comes to manufacturing, I wanted to highlight this upcoming idea, which is discussed at various societies, which is the point of care or decentralized manufacturing. Currently, CAR-Ts are either, for those approved CAR-Ts, they're mostly manufactured at the companies, at the site. So the starting material gets obtained and gets shipped to the companies. For some clinical trials, they can be produced within the institution like we do here at the U, but not all centers across the country or in the world are able to do that. But the goal in the future is, even for the approved products, can we make this CAR-Ts within the institution, or make localized manufacturing, decentralized manufacturing closer to the institutions? This is an ongoing process because of its many advantages. Finally, for monitoring response, biomarkers are very important. And for the future, really important aspect, like I mentioned, is the ability to sample products pre-infusion. And here I'm showing an example of a collection bag, which can be very crucial going forward, which is a collection bag that has a pouch connected to it. And one of the companies, the CAR-T companies that actually does allow us to sample a product, has something similar to this, where you collect the cells, but then you do have a pouch neck connected to it where you can also get some samples for testing. So I think adopting this in the future would be very crucial going forward. And for that, collaboration with industry and academia is going to be very critical. So that concludes my talk. I would like to finish by acknowledging a lot of people and that have been really important for my training here. I would like to start by thanking Dr. McKenna, who has been very, very helpful since my time here, since the first day. A great mentor and a great human being, and I've really enjoyed working with him and being mentored by him. I would also like to thank the program directors, Dr. Dolan and Dr. Johnson, for accepting me here and also being very flexible with my training and letting me do all the things that I wanted to do, including doing my fellowship before I finished my residency. The transfusion faculty, Dr. Cohn, Dr. Zanting, all of them have been really amazing. All CP faculty that during my rotations have been really great to learn from. Special thanks to Dr. Kargar, as Dr. McKenna mentioned. She was very critical in me coming here. And the first time I decided to switch from PEDS to CP and transfusion, I talked to Dr. Kargar, and she was very encouraging and helpful to show me the path that I did travel right now. And also MCT staff from cell therapy lab that I've worked with over the years, so they've been very helpful. I've also collaborated with a lot of people, like I mentioned in my project, HemOnc and BMT collaborators have been really helpful, especially Dr. Jacket. We've had other projects. For the sake of time, I didn't get into all of my projects and papers, but they've been very helpful, and we've published and worked together. Best collaborators, special thanks to Dr. Stronsek at NIH, who we have published together as well. Biostatisticians have been very helpful for a lot of my projects. And co-residents and fellows, Dr. Cox was my co-fellow last year, and also former fellows who I finished my projects with. And then finally, soccer and cell therapy go hand in hand. So we've had a lot of experience being on the field at the Loons game and a lot of exciting times. So just wanted to highlight some of the memories. And then this is from graduation last year. And then finally, my two worlds from Mayo and here collided at the annual meeting, where Dr. Epen was my inspiration in third year of med school when I rotated in the cell therapy lab at Mayo. And Dr. McKenna here, we met in Paris, and that completed my journey here. So with that, I would like to thank all of you for listening, and I think we have enough time for questions, so I'll be happy to take questions now.
Well, Teddy, I'll start off. Fantastic talk, and I want to really thank you for that. I've thoroughly enjoyed that. I have a very broad general question. I really appreciated your emphasis on calling this a cell therapy lab and not a cell manufacturing lab, because cell therapy, of course, implies that the people involved with the lab are actually treating patients as well as manufacturing these cells. My general question has to do with what's going to happen in the future as these cell therapies get more widely distributed. As you pointed out, that there will be CAR T cells that will be directed right at solid tumors as well as hematopoietic tumors. And this is coming down the line very, very quickly, meaning that these treatments will be very widely distributed and will be used in many, many institutions, not just highly academic institutions like this one. When you go to many of those institutions, the transfusion medicine service is covered by a pathologist who generally does not have transfusion fellowship training. And my concern is that, are we really training our residents who are going to go into these kinds of practices well enough in cell therapy to be able to handle the requirements once they get into practice?
Thank you, Dr. Crossan. That's a very good question. I don't know about other institutions, and I think this needs to continue to improve. But here, we do have residents kind of have rotations, both in transfusion medicine and cell therapy. But you're right, things are getting more and more complex and developed, and I think that's why now the cell therapy fellowships are continuing to grow, and we do have one here as well, and a few institutions are opening those. So I think those are another important avenue where fellows could specialize. But I think for just regular pathology residents who didn't specialize, I think we need to increase maybe the cell therapy fellow rotations. And currently there are electives. Maybe going forward, as we increase and these therapies become more and more, maybe the cell therapy rotations may need to be required by all CP or other residents. I don't know. This is a discussion at the higher level going forward, but that's a very important point to point out.
Well, yeah, the reason I asked that question is that I'm concerned that many really good pathology residencies do not include much of this. And so we're going to have general pathologists out in the community at places where they're using really high sophisticated CAR T cell therapy, and they're not going to know much about it.
Yes, you're very right. And even when I interviewed for my CP residency, I remember some institutions that was very important for me to make sure, like, do they have strong, cell therapy program? And I was surprised at some places they don't even rotate in apheresis, let alone transfusion. And because apheresis is being handled by hemonc. So yeah, that definitely needs to change going forward as things expand. Thank you.
So thank you.
Yes.
Congratulations on an excellent talk. Congratulations on those nice papers. And it's just so exciting. I think mine is more of a comment and maybe a little bit of question-ish. And likely a continuation of what John just talked about. So I noticed that you mentioned the cell therapy coming to solid organ, and that is not coming, it is already here. Right. So, and one of the challenges around that is having to change the laboratory workflow. So it's a little bit more complex than, just saying, okay, now it's going to really be happening. So, for example, our policy manual requires every specimen that is removed from a patient to come to pathology lab. And within the lab, we have two categories of those that are gross only and those that have to be processed. And so all those have to be written. Now we are getting to a situation where we have to receive specimen that has to remain sterile. And we don't have the capacity for that. So a lot of work around is going to need to be taking place. And I just wanted to bring this one up in this forum because we have trainees, we have everybody. This is going to be a challenge. It's an exciting challenge because it's an improvement on what we can offer our patients in terms of therapy, but it's going to be a challenge nevertheless. So we've tried to look for some innovative ways to work around that so that we still fulfill the terms of credentialing and accreditation without standing in the way of these cell therapies. So that's just my little comment, but thank you again. Very nice presentation.
Yeah. Thank you. Thank you for the comment. And I think that's why, like I mentioned, collaboration across the different departments is going to be very critical going forward. Thank you. I think there's another question.
For Zoe?
Zoe? You're still muted if you're trying to speak. Okay. Looks like, oh, are you back, Zoe?
Hello?
Yes, we can hear you now.
Oh, great. Thank you, Teddy. This is a fantastic talk. It's very interesting. And I'm just curious about a couple of things. One, so when you guys do, and this might be more of the second part of your talk that talks about the development and things like that, I'm aiming towards the biomarker kind of development approach. And so when you guys do the transfusions, transformation of the cells, two things. So you guys, after these get infused into the patient, do you guys have leftover and you save them? Can you reuse them for later, or that's it? That's one-time use and there's no more substrate to use from it? And if there is, do you guys do any analysis and studies on the cells that were already before, pre-infusion? And second question is, what is exactly can you elaborate a little bit more about the biomarker, such that what do you think is the ideal biomarker in a way? You talk about the different criterias, but are you looking for, let's say, lipids or, metabolites or proteins, and what will that be? And so what is being done in the field, what technology to kind of identify this ideal biomarker to follow up, right? So I'm thinking about, in a clinical lab, like which marker would you like and what can be brought in the clinical chemistry to help in that sense.
Yeah, thank you, Zoe. Those are very good questions. To answer your first question, like I said, that's a very good question. And we hope that was possible where after you infuse, you have some leftover, or before you infuse, you can get some samples. Like I said, currently, especially for the approved products, the companies don't let us do that because they want to infuse completely and they don't want any contamination. But that's why I said in the future, we really need discussions in terms of how do we get these samples from the products that are pre-infusion. So currently we don't do that. So it's really based on retrospective analysis of like, how did they do? And then it's really, and most of the data that we have is from clinical trials, not currently approved products. So that's the challenge going forward. And in terms of what ideal biomarker is, currently that is not, we don't actually have the answer. And that's what we try to do in that review, is trying to come up with that from the list of different biomarkers that are being studied. And currently there's no specific protein or gene type or metabolite that is like the ideal one. But like I said, there's various different kind of, from chemistry side, for example, you know, we've seen LDH or the various cytokines could be the markers that could be chosen. But currently we don't have a specific one that has been identified, and that's work in the progress in the future, where everybody has to come together and choose, okay, these are the best and we should focus on these ones. So currently I don't have the answer for you. So thank you.
Okay, and that's all for today. Thank you very much, Teddy. Good job. We will see you all next week.
Yeah, thank you everybody for your attention. Have a good day.